Hello, today we'll be presenting on a case scenario involving a patient with urinary symptoms. This presentation will be presented to you by Yuri Cho, Kevin Fain, Jessica Kropp, Kevin Navarrete, and me, Brendan Puhorajan. The patient's chief complaint was, in her words, "I have been having painful urination, nausea, and right flank pain for the past week." History of present illness. A 63-year-old Caucasian female arrives at the clinic with complaints of slight fever, dysuria, cloudy urine, nausea, and right flank pain for the past week. She shared that she has been more frequently using the restroom with a sense of urgency, does not feel her bladder is empty after using the restroom, and often has incontinence. She says the pain has been worsening the past 3 days, and has tried taking 500 milligrams of acetaminophen every 8 hours for the past 2 days, but it still did not help her pain. She states that her pain is at an 8 out of 10. She also stated that she has not been sexually active for the past 2 years after her husband had passed away. Premenopausal symptoms were shared and were stated to start at age 50, and a menopause officially ended at age 55. The patient has 2 children. Past medical, family, and social history. The patient denies a history of diabetes, hypertension, stroke, cancer, coronary artery disease, and other chronic conditions. She also denies any surgical history. She has no known drug allergies and no known allergies. Her mother had hypothyroidism and her father had prostate cancer. She denied any other familial history of diabetes, coronary artery disease, hypertension, stroke, and other chronic illnesses. As for social history, she reports drinking 2 glasses of wine every week and denies any smoking or illicit drug use. She was once a social worker but is now retired. As for medication, she takes Oscal, a 500 milligram calcium and 200 units of vitamin D3 caplets calcium supplement, 1 tablet every day.
When going through the review of symptoms, the patient mentions several symptoms she is experiencing. These symptoms help narrow down our assessment of the patient. She's feeling febrile. She complains of right lower flank pain. She admits to nausea, and she is experiencing burning and painful urination with incontinence, sensation of incomplete voiding, as well as urine appearing cloudy. When taking the patient's vital signs and performing the physical exam, our findings include the patient having a temperature of 100.6 and CVA tenderness. Take a moment to answer the following question. What examination technique can be used to help further differentiate an upper UTI from a lower UTI? Is it A, Lockman's, B, assessing CVA tenderness, C, palpation of the abdomen, or D, Gerber's test? The answer is B, CVA tenderness. Upper UTIs typically involve the kidneys, so assessing for CVA tenderness is important in formulating the differential diagnoses.
Okay, so here are some tests that are done for suspected urinary tract infections. One is percussing for CVA tenderness. This is done at the space between the 12th rib and the spine, where each kidney should be located. And percussion that causes tenderness can typically identify a pathology of the kidneys or an upper urinary tract infection. It's important to understand that while this typically indicates pyelonephritis, there could be kidney or ureter abscesses, there could be a UTI, or a stone in the kidney or ureter causing this pain. It could also be due to appendicitis, so it can be important to do an abdominal assessment if there's any positive tenderness. And it can also happen from conditions like sickle cell anemia causing obstructed flow from the kidneys. The next video shows how to perform a UA, and it can be helpful in educating a patient on the proper technique for washing your hands and then cleaning the area and performing a clean catch specimen. So here's some So here are some results and interpretations that we would do for lab work for a suspected UTI. A CBC can be done to look for infection, inflammation, and also check for anemias. The BMP can help check for electrolyte abnormalities as well as a decrease in filtration rate or high creatinine to look at kidney function. And the UA will help with looking at different markers in the urine. Here we can see that the urine was dark yellow and it was positive for nitrogen, and leukocytes, which could indicate a bacterial infection, leaving some waste products in the urine. There was also white blood cells casts that were present, which can indicate some tubular damage. The CBC showed elevated white blood cell count consistent with infection, and an ESR and CRP that are both elevated, which can help also identify that it's pyelonephritis causing inflammation. The culture was completed and the bacteria was found to be E. coli.
Differential diagnoses. So our primary diagnosis would be acute pyelonephritis. She was positive for flank pain, nausea, CVA tenderness, fever, positive for leukocytes in her urine, and also positive for E. coli. However, the urine culture did not show any colony-forming units, although she did test positive for E. coli in her urine. The next diagnosis would be a urinary tract infection, as she experienced dysuria, had sensation of incomplete voiding, had cloudy urine, and a sense of urgency. However, there was no sign of blood in the urine. The diagnosis after would be pelvic inflammatory disease. She had a fever of 100.4 and dysuria. However, she did not have lower abdominal pain, no blood in between periods, and no discharge. The next diagnosis would have been cholecystitis. She tested positive as she had a fever and she had nausea. However, she had no upper right or center abdominal pain, as the pain was located on the right flank. She had no vomiting, no jaundice, and she did not have any bloating. Our last differential diagnosis would be appendicitis. This is because she had nausea, fever, and loss of appetite. However, she did not have any vomiting, she had no abdominal pain, and no rebound tenderness.
Question: what triad is typically present with pyelonephritis? I'll give you time to read those. The answer is A. Fever, in this case study, we would diagnose the patient with acute pyelonephritis, classically presenting as a triad of fever, flank pain, and nausea or vomiting. This patient presents to us with a temp of 100.6, flank pain, CVA tenderness, pyuria, nausea. Her labs were positive for elevated ESR and CRP. White cell casts were present, and positive leukocytes indicate UTI. Her pain was rated as a 8 out of 10 and have been worsening over the last 3 days. The location is in her right flank with dysuria. Risk factors. In a study of young and middle-aged women presenting to an emergency department with fever, pyuria, and other features of upper UTI, 98% of them had acute pyelonephritis. And with the patient in her early 60s, she would fall into this category. Her white cell casts, those are specific for acute pyelonephritis. Urine cultures are positive in 90% of patients with acute nephritis. Pyuria is present in nearly all acute pyelonephritis cases and can be detected rapidly with a leukocyte esterase test. The first line treatment of acute pyelonephritis is oral ciprofloxacin, 500 milligrams BID for 7 days. However, due to the safety considerations of fluoroquinolones in the elderly, we would prescribe this patient with the second line treatment, which is Bactrim. We would give it to her orally, 160, 800 milligrams BID for a course of 14 days.
In light of the USPSTF not having any recommendations regarding pyelonephritis, the guidelines we have included in this presentation are for the screening of asymptomatic bacteriuria in adults. The USPSTF recommends screening for asymptomatic bacteriuria using urine culture in pregnant persons, and they gave that a grade B recommendation. However, they recommend against screening for asymptomatic bacteriuria in non-pregnant adults, and they give that a grade D recommendation. As far as education goes for this patient and her diagnosis of acute pyelonephritis, we want to focus on prevention of any future cases of pyelonephritis. Therefore, it is important to educate her on what to do after going to the bathroom, such as wiping from front to back. Additionally, although the patient reports that she has not been sexually active since her husband died 2 years ago, we want to educate her that she should void before and immediately after intercourse to help stop the introduction of bacteria into the urethra. We could tell her that there have been studies testing the efficacy of cranberry juice, probiotics, and low-dose prophylactic antibiotics to prevent UTIs. We should also tell her to avoid recurrent acute pyelonephritis, she should complete her entire course of antibiotics and take them as directed. Finally, we can educate her on the importance of hydration and the prevention of acute pyelonephritis, and discuss the benefits of staying well hydrated and improving kidney function.
References. Below is a list of references that we use for this presentation. We hope you enjoyed the presentation and learned much about acute pyelonephritis and the different labs and examination techniques we would use to help differentiate this diagnosis.